Now we'll talk about DDH. What is DDH? DDH is developmental dysplasia of hip. Earlier it was known as congenital dysplasia or congenital dislocation of hip. But why now it is known as developmental dysplasia of hip? Because it is over the period of time it is found that it is not congenital. It is developed over the period, whether it is developed intrauterine or whether it has developed in early newborn phase. Okay. So DDH, developmental dysplasia of hip. This can be asked as a long question in your final exam, or there are a lot of questions which have been asked on this. A lot of MCQs have been asked on this particular topic, but you should prepare this as a long question for your final exam, final professional exam. So DDH, it is basically a spectrum of conditions which includes 1. Dysplasia, okay. Second, subluxation. Third, dysplasia of hip, subluxation of hip. Third, dislocation of hip. Fourth, teratologic hip, teratologic dislocation of hip. Now dysplasia, as we all already know, it is a shallow or underdeveloped hip. Now if dysplasia is there, this can lead to subluxation. What is subluxation? That is partial dislocation. This subluxation can lead to dislocation. But what is teratologic dislocation? When dislocation occurs intrauterine, then it is called as teratologic dislocation of hip. And this teratologic dislocation of hip is associated with various syndromes. The patient is usually syndromic. If this dislocation is present intrauterine, then you call it teratologic dislocation, and this dislocation is then usually associated with various syndromes. Okay. Now let's talk about features of DDH. What are the features of DDH? This is most common pediatric orthopedic disorder. Peds orthopedic disorder. Some people say that every child should be screened for this. But then there are American guidelines that only high risk screening should be done for DDH, not in every case. Okay, because then it leads to a lot of patient load and it is not cost, and after doing cost benefit analysis, low risk screening is not recommended in this case. Only high risk screening is recommended. Okay, so for that high risk screening we should know what are the high risk factors. I'll tell you that. Then we come to, it is usually unilateral. Left side is more common than right. Okay. In 20% cases it can be bilateral. It is more common in females than males. Okay. This is again more common in females, and that too in left hips rather than right hips. Okay. Then let's go on to the risk factors. Now what are the risk factors? Risk factors are firstborn child, female, left side hip, Okay. Besides that, breech delivery, right? If there is family history, alright. If there is oligohydramnios, or you can call it packaging problems. What is meant by packaging problems? Packaging problems not only include oligohydramnios, it can be associated with twinning. If there is less space intrauterine, if oligohydramnios has occurred, if there is history in family, if there is chance of breech delivery, if the usually risk factor is that left-sided hips are more common, females are more common, and firstborn childs are more common. Why it is more common in female? Because it is implicated that it is associated with relaxin hormone. Now relaxin hormone is released by a female, so it acts on a female. If the child is female, this leads to relaxation of the ligament, which leads to laxity of the hip joint capsule. If hip joint capsule is lax, this leads to subluxation or dislocation and dysplasia. Right. So after this, we have to move on to the associated conditions, which is again very important. Risk factors MCQs have been asked on risk factors, these risk factors. Make sure you remember them nicely. Now let's move on to the associated conditions. Again, MCQs have been asked on this question on associated conditions. Okay. Now associated conditions are: number 1, congenital muscular torticollis, metatarsus adductus, congenital knee dislocation. In a patient with we call it CDK, congenital dislocation of knee. Okay, metatarsus adductus, congenital torticollis. In patient of CDK, it is always recommended to check it. So these are high. So you know the high risk factors, you know the associated conditions. So all these factors will make up. Whenever you find out any one of these, you have to screen the patient. You have to screen the patient with the help of that I will tell you. Okay. Now the classification. It is classified as dislocatable, dislocated, subluxatable. So this is least severe, middle severe, most severe. Okay. So it can be broadly classified as subluxatable, dislocatable, dislocated, subluxatable, dislocatable, dislocated. Then you come to physical examination. On physical examination in a less than 3-month-old child, the mainstay physical on examination in less than 3-month-old. Why I am writing less than 3-month-old? Because in children of less than 3-month-old, the classical tests, that is Barlow test and Ortolani test, they are informative, but after 3 months they are of no use. Okay. So Barlow, as the name suggests, Bahar low, and ortolani has to be opposite of it. Andar lo. So bahar lo means you have to, this is a provocative test, you have to dislocate the hip. So you have to dislocate the hip. And here you have to relocate the hip. So there is a click or clunk of relocation when you relocate it. Here is a clunk of dislocation. Alright. And then there is third test known as Galeazzi's sign. This is same Galeazzi of Galeazzi fracture. So here what he did was he made the patient lie supine and he measured the heights of femur from front and tibia. So it was found that in Galeazzi test, it was found that this thigh length was smaller in case of dislocated or dysplastic hip. Why? Because hip was dislocated and it has gone back, so the thigh length will become smaller as compared to the opposite side. Okay. Then it is DDH and the hip is not there in the acetabulum. So there is Narad's sign. What is Narad's sign? Narad's sign positive means femoral artery pulsations, because you feel femoral artery pulsation against femoral head. If femoral artery pulsation is weak or absent, then this is called as Narad's sign positive. Okay. So in a patient with DDH less than 3 months old, you have these findings, and in a patient with more than 3 months old, these Barlow, Ortolani, they have no significance, although Galeazzi and Narad are still significant after 3 months of age. But the most significant is loss of or decrease in abduction. Right, abduction is decreased. Abduction is decreased after 3 months. Why? Because of contracture, adductor contractures. Right, the hip is dislocated and the limb is adducted, so there will be formation of contractures in the adductor compartment or on the medial capsular side. So there will be loss of adduction or complete absence of adduction. Right. Now we'll move ahead with imaging. In imaging, there are to know whether hip is located or whether hip is dislocated. Radiology. The first most sensitive test for DDH or investigation of choice for DDH, this is ultrasound of hip joint. Ultrasound has a limited indication in musculoskeletal system, although these days people are coming up with various modifications, but overall speaking, ultrasound, whenever you at your level, when you are reading ultrasound, so you won't find it anywhere else except for septic arthritis or anywhere. but ultrasound has found its place here in DDH because head is cartilaginous. It cannot be viewable or it cannot be viewed on X-ray. So that way ultrasound plays a great role. Okay. But then they can ask what is best investigation. So best investigation is MRI. Okay, as I've already told you, whenever they ask you anything in orthopedics, what is best, just mark MRI without thinking, wherever you are stuck. So in this case also, this thing. In fact, ultrasound, this is used for high risk screening. And there is a classification based on ultrasound. You don't need to go into detail of that. And now on X-ray, because X-ray is favorite of orthopedicians. Without X-rays, we don't see anything without X-rays. X-rays is the first thing we see after clinically assessing the patient. So X-rays are our best friends. So in X-rays, what are the signs that your hip is dislocated or your hip is relocated? So the signs are number one is the Shenton line. This line, if you follow this line from neck to the head, this till obturator, till this is a continuous line. This is known as Shenton line. If Shenton line is continuous, that means hip is reduced. If Shenton line is broken, that means hip is dislocated. Okay, so you have to look for this Shenton line. There are two other lines. Number one is Shenton line. Number two is Hilgenriner line. H for Hilgenriner, H for horizontal. 3 is Perkins line. P for Perkins, P for perpendicular to Hilgenriner line. So the second is Hilgenriner line. H for Hilgenriner, H for horizontal. Hilgenriner line, it is basically a horizontal line passing through bilateral triradiate cartilage, and Perkins line is perpendicular to Hilgenriner line, and it is perpendicular to Hilgenriner line and it passes through lateral edge of acetabulum. So radiology in this case is important again. The most sensitive test for DDH or investigation of choice for DDH, ultrasound of hip joint. It is also used for high risk screening. Obviously it is most sensitive and it is investigation of choice, and it is cost effective as well. So it is used for high risk screening. Then it is, second point is what is best investigation for DDH. The second point that is best investigation for DDH is MRI. Then you come back to the X-rays. X-rays has we have three lines which help you decide whether your hip is relocated or your hip is dislocated. Right. So first line is known as Shenton's line. Shenton line, if you track the border of your inferior border of your neck of femur, and it goes down till your pubic rami, it is a continuous line. This is known as Shenton's line. Second is Hilgenriner line. Your Hilgenriner line, H for Hilgenriner, H for horizontal. This is a line which passes through bilateral triradiate cartilage. It is a horizontal line which passes through bilateral triradiate cartilage. In case of dislocated hip, what is the relevance of Hilgenriner line? if it passes through this bilateral triradiate cartilage, in case your hip is dislocated, okay, so this line passes above the head, or your head is below Hellgen-Wiener line, okay, and the Perkin line, it passes through the lateral edge of this. So we use both of these lines together to find out whether it is dislocated or relocated. If it is dislocated, the inner quadrant is empty. This inner quadrant is empty. Okay. So remember, perpendicular line is Perkins line, horizontal line is Hellgen-Wiener line, and the third line is Shenton line. These lines help you decide whether your hip is dislocated or relocated. Okay. Now since you have made your diagnosis clinically as well as radiologically, now what will you do? What will you do next? After making diagnosis, what will you do? After making diagnosis comes the part of management. So what will you do and how will you do management? In orthopedics, except for orthopedic emergencies and obviously in fractures, most of the part we first go for non-operative, unless it is indicated primarily. It is one of those conditions where we first try our non-operative management. If our non-operative management fails, then we will go for operative management. Because operative management in this case is not an easy job. We are dealing with such a small acetabulum and hip, and operating upon acetabulum and hip in a child is not that easy. So our first thing is conservative management with the help of Pavlik harness brace. This is very important, and this has to be used in a child till he is 18 months of age. Because if we don't wait till 18 months of age, then it will be too early to perform a surgery, and even after that, if we continue after 18 months of age, then it will be too late to perform a surgery. So this is all evidence-based orthopedics. So we do it till child is 18 months of age. So once the child is 18 months of age, so at 18 months, if hip is okay, nothing is required, everything is fine. At 18 months, if hip is still dislocatable or subluxatable, then we have to contain it. We have to perform operative procedures. But before performing operative procedures, what we do is, this is a dynamic brace. Pavlik harness brace is a dynamic brace. That is, what is dynamic brace? Dynamic brace is with one movement, your culprit movement is corrected automatically. So this is dynamic brace. But in patients of 6 months to 18 months, okay, at 18 months, till 18 months we can go for Pavlik harness. But between 6 months to 18 months, we can also try hip spica. For example, in a case, till 6 months of age, you have given them Pavlik harness brace. Then after 6 months or at 6 months, you have seen that the severity has increased, or it is still dislocatable in a particular position that you don't want, that is not being stable with Pavlik harness brace. So at that point of time, you decide to give a patient a hip spica, which is obviously a static brace, you can say. So hip spica can be given between age of 6 to 18 months. But after 18 months, what you do is, hip is still dislocatable, hip is not okay. Okay. So here you can do open reduction plus hip spica. Or if there is a possibility that the patient directly comes to you after 2 years of age. If the patient is more than 2 years of age or has failed this, ये fail हो गया है और patient का age is more than 2 years, then you have to perform containment procedures. Which can be femoral osteotomies, or it can be acetabular osteotomies. Okay. But what if a patient comes to you after, suppose a patient comes to you after 8 years of age, more than 8 years, do nothing, observe. So a patient at this age, it is very difficult to do a containment procedures, and most likely those containment procedures will fail at this age. So in these cases what you do is you just observe them till adulthood, and later on, because they are very prone to develop hip arthritis, secondary osteoarthritis, so just observe them till adulthood, and later on you can replace the hip. Alright. Let's come on to complications. So the complication is, the first and foremost is osteonecrosis. It is AVN. Obviously a hip which is dislocated, less blood supply leads to avascular necrosis. Okay. It can be because of chronic placement in pelvic horn splint. If you just place it so much of abduction, it can lead to jeopardization of blood supply of the proximal femur. So this can also lead to osteonecrosis. The second is delayed diagnosis. If a patient comes with delayed diagnosis, or primary care physician is not able to make the diagnosis, he is not able to find out whether it is DDH or not. So by that time things have already occurred. For example, if a patient came after 8 years of age, you won't be doing anything. If a patient comes at suppose 3 years of age, you straight away have to operate. You don't have to wait for hip spica and pelvic horn splint. Then there can be transient femoral nerve palsy with pelvic horn splint or spica, with splint or spica. Okay. And there can be recurrence with those spicas and splints. And then there are complications of surgeries. Complications of surgeries are again osteonecrosis, recurrence, or failed surgery. Right. Now we'll go on to, we are done with DDH. Every point that I have said in DDH is an MCQ. Okay, I have not said anything extra what is written in books, any unnecessary thing. I am not touching into this video any unnecessary thing. Whatever is needed, on all those topics, wherever in MCQs is asked, I am just touching that points, so that this video turns out to be a very high yielding video for you people. And orthopedics is very vast, but the amount of questions that are being asked in an exam are not that much as compared to the vastness of the orthopedics. But let's stay focused on studying just high yielding topics. Okay. So whatever I've told you in DDH, you can easily cover your long question for your final exam viva, and you can easily solve all the MCQs that have already been asked in DDH till now. Okay. Specifically, you should focus on associated conditions. It is very important, and management. Management is also very important. Okay, and that Ortolani and Barlow test is also important.